Time for questions. So we were saying that the time was long, but I will try to be as fast as possible. Thank you very much. Thanks for coming back. Well, when I was invited, I also thought that we could also discuss about some ethical problems and legal problems. Even though they seem to be interwoven, these are two separate areas and they have subcategories. And I will try to be as short as possible and fast as possible. Of course, psychiatric diseases are far from desperate and untreated. More female psychiatric patients come across the perinatal periods. Because of falling birth rates and increasing public roles of women, the state of being pregnant mean much more than before. The roles have changed, the expectations are different, and there is falling birth rates. Therefore, having a healthy baby is more important than ever at the moment. This is a quotation from Ulrich Beck from his book. He says that we are living in a risk society at the moment, and in this risk society, when there is an influence or stimulus from outside, there is a wrong perception that we can prevent it in advance. So when this is the case, which is the doctor, which is long respected by people or researchers who were respected and trusted before, are not omnipotent anymore in the eyes of the patients. Therefore, the people are more concerned about the risks they may encounter. So in this context, in relation with the development and advancements in the medical sphere, there is a tendency to use this specific scientific innovation, but there are some suspicions regarding this innovation. Of course, they are right in a sense. Of course, we cannot say that if you take the drug, you are going to get a pathology for your baby. We cannot always say that, and we cannot say that your baby is going to have an Epstein's abnormality in the rate of 2%. We cannot say it, of course, but it's not all black and white. There are gray areas as well. So more information means more concern as well. So to what extent we assess the risk? First of all, when we look at the risk, the perinatal risk is a very broad concept. The preconception period and the early pregnancy period, pregnancy itself and postpartum period when the mother is breastfeeding, the risks are very much multidimensional. So all of these risks are different from one another. From a theory perspective, documenting and listing and evaluating and submitting all the risks is not possible. So when there is a problem or a challenge, in other words, when there is a heterogenic result for the infant, who is going to be responsible? The patient, the psychiatrist, or the psychiatric intervention? This is also a matter of discussion. And moreover, the women cannot be a little bit pregnant. We cannot, for example, say, I'm a little sick or I'm more sick. Therefore, the earlier detection of pregnancy is more possible at the moment. But this cannot, of course, pave the way for intervening at every bad result. So psychologically, pregnancy is a reconstruction period of the change in the role and identity. So there are many dynamic problems in terms of transiting to pregnancy within the family and outside the family, and the terminology, which is happily ever after, cannot be used. There is cultural perception. Different ways of psychiatric treatments are restricted by obstetric and fetal risks. So different perceptions are discussed, and therefore they have to be taken into consideration. Ethics is a very popular matter which is discussed by many disciplines at the moment. It is very much voiced at the moment. My personal opinion is that, of course, each branch is very valuable and very important from ethical point point of view. And in terms of private discourse, it is very interesting, of course, but psychiatry and obstetrics are very much related and similar to one another. A woman coming to an obstetrician and coming to a gynecologist and a psychiatrist require the same level of privacy, I think. This is my personal opinion. It's not because that I'm a woman, and no psychiatrist will say that a woman came to me and had this problem and that problem, just like an obstetrician who would never talk about the examination, physical examination. Before everything, we have to ensure a utility. We have to be of benefit for this women. From ethical perspective, this should be our first purpose, and that should be the first thing we should utter. But the main problem here is that we can be of benefit, but what's going to happen to the baby? This is another question that should be posed. And we have to follow up-to-date literature. Because of existing restrictions and limitations, no large-scale activity or study is carried out. So you cannot say that in this percentile or at this percentage your baby is going to have this and that problem. So we cannot say this to the patients. It's a very important point, and I will ask Nin of course, to talk about that maybe in a minute. There should be mother and baby units, and there should be specific units which will be dedicated to the problems of these women. We will talk about that. Of course, respect to autonomy is very important. The person should have the right to self-determination, and we have to respect to the decisions made by the patient. The patient's values, beliefs, and her rights to choose between different alternatives should also be respected. The patient may have a psychiatric disease, but this does not mean that we should be acting against the values and beliefs of this person. Yes, respect to autonomy is one point. However, what if we hurt the baby? Are we going to give the priority to the mother or to the autonomy of the mother? This is another dilemma and point of discussion. Therefore, in summary, in the foreign literature, there is something that is emphasized. If the mother is mentally competent, that if your personal opinion is that mentally competent, if you think that the mother has the mentally competence to make a decision, then you should ensure that the person should have the right for self-determination. Yes, there can be episodes, but in cases of episodes you may decide on her behalf. However, in lack of episodes, we have to respect their rights to self-determination. Privacy is very important. Perinatal psychiatry is very, very autonomous in that respect, and it's very private. Personal information and personal data should be protected for these patients. Together with the multidisciplinary approach, we work together with people from different branches. However, just like the other patients of psychiatry, these people also need privacy. We, of course, have to have a just practice. Mentally ill and non-mentally ill patients should be treated the same. They have that right. During the examination, the patients, if they are considered to be mentally competent, then the patient should have the right to make the decision. There are detailed tests regarding pregnancy at the moment, and high-resolution ultrasounds are used, and there are very many tests about detailed analysis of the baby and the pregnancy. If you are suspicious of something, you request detailed tests. In that case, if the patient is not psychiatrically acute, and then the mother will have the right to make the decision. If the patient does not want any amniocentesis, you should not force the patient to have amniocentesis. Therefore, there are dilemmas as well. If you think that it is a must for the baby, or it is a must for the mother. If the patient refuses a treatment, what's going to happen? And we're going to dwell on this from a legal point of view. There is a concept called directive counseling. From many perspectives, in relation with informed consent, our experience is getting more and more, and I'm very happy about that. So, first of all, this has to be explained orally. You should not put it in front of the woman a paper which contains very small letters, and you cannot just ask them to undersign it. It is very easy to do, but we have to make sure that the woman understands what is written there. Laura Jane Miller has a very good article on that, and I still believe in the rightness of that. We have to make sure that the patient understands what's written there. The people who are in the military know it very well. It's the repetition of the duty, and we have to make sure that she understands it, and we may ask to her to rephrase it in order to check whether she understands it or not. It's a very simple method, I think, and it's very effective. So when they are given the chance to paraphrase it, their chance of trauma is going to be decreasing as well at the very end. So directive counseling is including this as well, but it should not come to a point of forcing them. As you know, coercion or forcing is not an ethical act, and it also causes trauma after. For example, I had a case. The family did not want the baby because the woman was using drugs, and because of the physician and because of the family's coercion, the woman had abortion, but then she came to me because she had enormous feeling of guilt. So while we were trying to save the baby and save the patient, they are having a secondary trauma at the very end when we can make them sick. So unlike paternalism, in directive counseling, the clinician's decisions are not superior, or the patients shouldn't accept the clinician's recommendations unquestioningly. So omission is very important as well. Generally speaking, it is also seen increasingly in our country as well. We are dealing with the families and we are dealing with the lawyers, and it's troublesome for us. So when this is the case, the physicians are more reluctant to give the treatment. So this means that the physicians, instead of giving a harm because of something they do, they would like to prefer a harm because of something they do not do. One of the participants asked a question, so do we have to give that drug or not? So which is more harmful, he asked. I think that patient may have some problems, but having another episode and having hospitalizing her and giving more drugs is more traumatic. So these secondary episodes can be more complicated and maybe more challenging. Therefore, the physicians should be more courageous, I think. We talked about informed consent. Of course, more possibly, we have to talk about different issues and repeat the items and request them to repeat it, and we have to make sure that the patient understands what is written there. But if abortus is going to be a choice, or sterilization is going to be a choice, and when there is a legal document about the custody of your children, and if a signature is required for that, it should be in a period when the woman is non-psychotic. Especially with regard to abortion, of course, the confusing thing is that for Turkey, abortion can be done until the 10th week of pregnancy. That's something legally stipulated. Let's say that after the episode, it is already 13th week. So maybe on the 13th week, the woman is going to make a healthy decision. Then we are beyond the legal boundary. So at a very early stage, in that case, the psychiatric problem of this woman maybe should be reported to the relevant authorities. But if you ask my personal opinion, I think this has some ethical considerations as well. In that case, the people who is going to have the guardianship for that woman is going to make the decision. Maybe after the psychotic episode, the woman may find out that the decision is already made on her behalf. So the women, this type of women should have the right to carry out the abortion in later weeks. I think there should be an open ending in the law. Just like other adults, not just like other adults, but for this woman, the abortion we should be able to do abortion in the 13th week or the 14th week. So it should be the case, because the woman should be able to make the decision for herself after the active episode, but right now the guardianship is a must. So involuntary mental hospitalization is another thing at the moment. Right now in Turkey we do not still have a mother and baby unit. We have something in Konya, and Faruk Bey is here amongst the patients. I know that he's doing it, but I know that actively speaking, we are accessing more patients, and we do not have inpatient mother and baby service. So we already have an unethical behavior there. In order to avoid harm to the baby and to the mother, we are planning hospitalization, but we are encountering the risk that this woman is going to get more risk of doing the inpatient service. Nobody is having benefit at the very end. Maybe legally we are protecting ourselves because we do have the certificate of discharge, and we have the patient undersign the informed consent form, but in that case the patient is surviving without treatment. So this is the civil law article number 432. It is a bit long. In order for the participants to understand it in a better fashion, I translated it into English. If there is a mental illness or a psychiatric problem, of course there are many conditions in this law, but the freedom can be restricted through a court decision. But the warning Bakırköy is making a warning to the court. We have such a court, but the results and the conclusions and the judgments are coming to us in a very late fashion. Therefore, yes, we do it. Yes, we fulfill our responsibility, and we enact the duties under 432. But we cannot really protect the patient. But the person whose freedom is restricted is discharged from the institutional as soon as she gets okay. So there is the civil law article number 405 about guardianship, and the guardianship can be given to a second person. This can be a lawyer, for example. This doesn't have to be a relative. So the court has full discretion on that. The abuses or the other things can be under the consideration. For example, the guardian of the person maybe is going to abuse the person financially, or because of some sexual reasons. For example, the person wants to be the guardian of this person, but this type of a guardianship is relieving us from legal point of view, but it is not really protecting the rights of the women. This is my personal opinion. This is a detailed, however, absolute nullity of the marriage. If one person is not informed about the psychiatric disease of the spouse at the beginning of the marriage, or during the process this disease may arise, so in that case nullity can be under the question for the marriage. Another problem, I'm very fast, I'm sorry, the other problem is custody of the child. 3% of women with psychosis were parents in a study, and their mothers This is a very high number, and it is 26% for men. In the psychosis of men and in the psychosis of women, the marriage rate is a lot different. So in perinatal psychiatry, we can always come across with these women. Another study is having 322 participants. Women with serious mental illness have lost custody at some point in the child's life, and this study was carried out in 2004. Of course, we cannot evaluate that risk. If this person is going to treat badly, and if there are bad habits, for example, these can be bad markers. However, we cannot say something 100%, and we cannot be sure 100%. I think this is a very nice way of saying it. She says that given well-timed, appropriate and adequate educational resources, many individuals with psychotic illness succeed in parenting their children. So this is very right, and majority of the things that we say that this person cannot make a mother, this person is not mother material, for example, this is our prejudice. If we can give sufficient time and effort and resources for these women, they can become very effective mothers, and if the social schemes support them, they can be very good mothers. You are talking about very good things and very nice things and very valuable things. I will be fast. You can either finish now and get questions, or you can just finish right away. So you have 0 minutes. You say a lot of things, and there can be a lot of questions already. I'm sure there will be a lot of things to talk about, but what would you like to do? So there's nothing else to do, I think. Let's get questions. Maybe I should just show the slides in the background. No.